thank you for the introduction, John. As he said, I've worked with benefit design specialists here locally, very involved with SHRM, much like, is it Matt Gurley? Much like Matt, I started down in York with a role on foundation, and then somehow got voluntold onto the state council, where I have gotten to know many of you over the past few years. My roles there include sponsorships for all of our marquee events, that is our annual state conference, our leadership conference, which Sam is the chair of, as well as our legal and legislative conference right up the road here. If you haven't made it out to any of those events, I encourage you to. If you're looking to get involved from a sponsorship perspective or have vendors or partners that are interested, please reach out to me. Outside of my day job, I just got married over the summer. I live here in Hummelstown with my wife, who's a second grade teacher, and we have a kiddo coming this July, which we're very ecstatic about. Much to what Gary had said earlier, my disclaimer before I start the conversation is that this is a very systemic problem that goes back a number of years, I mean decades. So while some folks might point fingers, I think that there's a lot of culprits that I'll discuss today that got us into the problems of where we're at. That could be providers, that could be hospital systems, the government, believe it or not, consultants, employers, employees. Everybody has a stake in this healthcare economy. What I'll show you today are a couple strategies to maybe combat that, some things to go back to your consultant or your vendor partners to discuss, and hopefully you find it intriguing and slightly entertaining. I will also throw out some pop quizzes, Price is Right rules. If you shout out an answer closest without going over, I got some scratch-off tickets here to give out so we can keep it entertaining, and if you win big, maybe you can donate the money to foundation or at least support it. Ta-da! So, believe it or not, you run a healthcare business, whether you like it or not. I think that everybody can agree that healthcare is a pretty large expense on their employer's balance sheet, correct? Usually the second largest outside of payroll, unless you have a substantial high claiming, which some of these claims can get astronomical. My good friend here, Albert Einstein, and this is kind of the premise of our conversation today. Sorry, it didn't come out correctly as it transferred over, but the world as we've created it, it is a process of our thinking. It can't be changed without changing our thinking and our perspective. So I want to flip the script in a lot of ways and think about why you purchase certain things in your plan or why you do certain things from a plan design perspective, as well as tell you a little bit of story way back when I first came out here after leaving Pittsburgh and started working for Novartis Pharmaceutical as a drug rep. So my job, after they spent 3 months training me and $120,000 in training, was to go out and convince doctors why my branded medication is way better than that generic alternative. For those of you in here that have high blood pressure, lisinopril is usually the first line of defense. It's an ACE inhibitor that's prescribed. It's been generic for a long time, costs about $5. My drug, Diovan, was a $2.5 billion drug for the company, and I was brainwashed in a sense to convince these doctors that it was cheap because I was giving out these waivers, these coupons to make it cheap for the patient. They weren't paying a branded $20 copay at the time. They got $5, just like that generic. And in these instances, the doc had no idea, outside of maybe some clinical speak, what that was costing the self-funded health planner in the background. Lo and behold, and if you can believe this or not, okay, here, first question. What percentage of doctors actually know the cost of the drug that they're prescribing?
5%.
It's a little higher than that.
20. 12.
Only about
7.
a little bit higher.
9.
A little bit higher. Okay. Closest without going. Only 26% of docs actually know what a drug potentially costs. I'd say that it's a lot lower than that based on what we see out in the marketplace, especially when you look at these high-cost specialty drugs and whatnot. Believe it or not, not all docs prescribe drugs based on the clinical studies behind it. St. Patty's Day, I go into a doctor's office, I'm wearing a green tie. Guy says, "You look like a leprechaun with that red hair," which I argue it's strawberry blonde, it's not red. I'm gonna write your drug. You kidding me? For those of you who know my llama story, I'm not gonna share it today, but if you go to justindleader.com and click on blogs, you can read a blog that I wrote a while ago called Life Lessons Learned by a Llama. I had an incident with a llama when I was a kid, and ultimately this spread like wildfire from doctor's office to doctor's office around central Pennsylvania. And I had a doctor who loved the story so much, he wrote my drug to the point, he was a high prescribing doctor, that I won Rookie of the Year in 2008, 2009 because of a story in which he didn't really know the clinical evidence behind my drug or the fact that it was costing these health plans, if it's a self-funded employer, $60 to $100 every time that script was filled on a monthly basis. He just thought that it was a funny story and I was a likable guy. So think about why providers might be doing something, what's the reasoning behind it, but what the financial implications are further down the line. How many folks here have kids? I should have bought more scratch-offs. How many have 3 kids? 4 kids? 4? 5? Anybody got 5? All right, I owe you a scratch-off, I owe you a scratch-off. I'm coming up for 1 on 7-Eleven. Just like the gas station, we haven't decided between Slurpee Leader or Slushy Leader yet, but it's up for debate. If you have any good names, I'm taking suggestions. But who can think back to a time that they went into an office, received a service, and had a fully transparent bill that's itemized, that shows exactly what the cost was for whatever service they were getting on that day? So this is from 1943, McGee's Fork Hospital, so about 8 years ago, right? Paid with cash, full labor and delivery, $29.50. Anybody want to volunteer what their cost was to deliver? Probably a lot more than that, right?
About 11 grand.
11 grand?
That was 15 years ago.
But did you receive a bill up front that you knew about, what the cost was?
So,
Okay. So as we're talking today, think about why you don't get to see things like this. Why there's a 3-month lag sometimes from when you get that EOB, which is coded, which has a little bit of a description about the service that you got, most of which is written in hieroglyphics that is hard for the average person to understand. There's a reason, there's a purpose behind this. The system is built to be difficult to understand so that the average Joe doesn't ask questions like, Adam ruins everything, which he did ruin everything today in our perspective. Emily did a great job on that. It's built to make money, essentially. So, in our current healthcare system, as of 2018, 2017 it was $3.5 trillion. As of 2018, we've spent $3.65 trillion in healthcare in the U.S., which is higher than the gross domestic product of quite a few of our neighbors and allies out there in the free world. Quick stat, just a guesstimate, how much of that $3.65 trillion could be attributed to fraud and or waste?
20%.
Probably 40, 60. 63.
Who said 40? It's actually 50%. 50%. So needless to say, we should be frightened from the perspective that we just came out of the housing crisis, correct? A massive bubble that burst. I would argue that we are on the verge of our next big bubble here. Frankly, people can't afford their out-of-pocket expenses. Employers can't afford, in some cases, to provide high-quality benefits like they used to attract and retain employees. So we live in a very scary time. Out of all bankruptcies in the United States, how many do you think are attributed to medical bankruptcy?
80%.
55? It's a little lower. 25, 26%. There's a lot of reasons for bankruptcy, but 1/4 of all bankruptcies are attributed to inability to pay for medical expenses. Out of those 26% of medical bankruptcies, this one is staggering. How many of those folks had health insurance? Plus what you read over. They said 75. 75% of those folks had health care. And that's where we talk about a problem in healthcare literacy as well as healthcare plan design. My man Warren Buffett, although Berkshire suffered a loss here in this past week, he is quoted as saying GM is a health and benefits company with an auto company attached. I think most of you can agree that your company, while they have that, maybe it's a manufacturer, you're responsible, or your revenue sources are from creating some sort of product, or maybe you're offering a service. Healthcare benefits and employee benefits occupy a substantial amount of your time and your rev. This can be seen in what we call real compensation per hour versus your average hourly earnings. Anybody do total comp statements or have done in the past? You know, a lot of people are like, you know, why am I not making more money? Why is my take home not as high as what it should be? This is a large portion of what's going on. You know, as your benefits rise, you don't have the revenue to be able to offset and increase wages in a lot of cases. The other avenue of this too, going back to what I'm talking about with plan design, I think there's two things that we do from a plan design perspective that aren't necessarily beneficial to the employee. You know, we preach consumerism and consumer-driven healthcare, and we come up with this thing called high deductible health plans. The issue is, it's like we give everybody a helicopter to fly to and from work, but we don't train them on how to fly that helicopter. Healthcare literacy, according to CMS, Centers for Medicare and Medicaid study here in 2017, meaning healthcare literacy, you can understand what copays, co-insurance, deductible is, plus basic medical terminology, is about what percent in this country? That's another question. You had to guess. Lower.
15.
They said 12. 12 to 14% healthcare literacy rate. So when you put into play these high deductible health plans, what kind of education are you doing to ensure that these people know how to go out and make a quality decision? A lot of it's very difficult because quality data, one could argue, isn't available. I think, is anybody familiar with Leapfrog? Leapfrog does a pretty good job of quality data. Quantrust does a pretty good job of offering quality data. But for the average employee, if it's not hitting them in the pocket, they're not really going to be too keen on looking for a solution to help pad their cost and incentives your cost as well. So when we talk about reference-based pricing, and I'll talk about direct contracting a little bit, think about incentives for the employee population to get them to change behavior. And doing your own research, or with your consultants or brokers, doing research at a local level to understand what the quality providers are in the area. I'll give you a couple names throughout the conversation, people that you should follow. Everybody, for the most part, has social media, LinkedIn, Twitter in some cases. We know the president does. One guy that I highly suggest you follow, he's actually our ERISA attorney, is Adam Russo of the FIA Group, PHIA. FIA Group, they have 250 attorneys and IT folks up in the Boston area. They were on the cover of the Boston Globe a couple years ago for this mind-boggling concept that they came up with for new births in their employee population. They identified 2 local facilities, hospitals, where most of their deliveries were happening. Mind you, their population's pretty young attorneys, young IT folks. One hospital, both facilities provide quality outcomes, births, etc. All the data's there. One facility cost $8 grand for that delivery. The other hospital up the road, equidistance, $42,000. So Adam amends his plan plan document, we'll talk about fiduciary responsibility and what you as an employer can or cannot do in your plan, and puts into the employee benefits booklet. If you decide to go to this facility voluntarily, we will pay for your diapers and wipes for 2 years, first 2 years after that child's born. After they did that, they've now had, over 3 years, 40 births at that one hospital. Now, I'm not a mathematician, but if you net out the difference, multiply that times 40, that's some substantial savings to the plan. And you think those parents are happy to get free diapers and wipes on Amazon Auto Ship on a monthly basis coming to their house? That's pretty cool stuff, right? All stuff that you can do within your plan. We talked about healthcare literacy and some of the issues there. I love this guy. HSAs. That's probably the other thing that I didn't mention. I said there were 2 things that we've implemented to plans is a strategy to curb cost. On one side of the fence, my finance side says HSAs are awesome. I'm financially savvy, I earn well, I can stack all my claims in a shoebox, put all this money away. If I need to pull it out at some time, as long as I have the claims, I can pull it out triple tax-free. I can grow it as an investment. But how much of middle America is not living paycheck to paycheck? Folks in here have blue-collar workers, maybe some that are not high earner salary folks. Is an HSA really a good option for them and their family? We all know it at open enrollment, which you all love, right? Greatest time of the year. It's like Christmas. At open enrollment, employees come in, they sit down, they black out, don't listen to a darn word you say, they flip to the end and say, what's the cheapest plan for my family?
Exactly.
Right?
Exactly. Don't look at the dollars.
In most instances, the HSA is a cheap option. We want them to go that route, and we think, hey, we're preaching, we're convincing them to be consumers of their, and good stewards of their healthcare spend. But what education are we providing to them to make a reasonable and responsible decision? In some cases we are, in some cases we're not. But I would argue that most families can't afford the out-of-pocket expenses with the current deductible health plans that there are today. Average out-of-pocket expenses for a high deductible health plan for the average employee nationwide, anybody want to take a stab what it is? You're good. $5,000. Bonus question, this is a $2 scratch off too. What's the average family savings in the United States? What's that? A little higher.
$1,000 or
A little lower.
less than 1,000.
So one could argue that most people are walking around functionally uninsured, right? One stub toe away from medical bankruptcy. Like I said, systemic problem. One could argue maybe they need to do a better job at balancing their family income. I argue maybe the plan design's to blame too. So how did we get to this point? There's a lot of competing interests out there. I'm not an employer, but I can vouch that I receive phone calls from vendors, probably at least 10 to 20 per week, trying to sell me something or sell me some voodoo math wellness program that's going to fix all of healthcare and take that guy that's eating 2 double cheeseburgers a day, smoking a pack of cigarettes, and drinking over at the bar here at the hotel every day. You're probably not going to change their behavior. But probably the biggest one is your broker. There's a lot of great consultants out there that are trying to do a great job to fix healthcare because they feel partially responsible for creating this issue. Some of the folks that you should check out, aside from the folks in this room, Gary, Emily, Bob, healthrosetta.org. Has anybody heard of the Health Rosetta? So this started a couple years ago. A gentleman named Dave Chase recognized some of the issues that were going on and got backing from some of the greatest minds in our industry. And everything that I'm sharing with you today, it's not stuff that, I just magically know. We learn from experience, we learn from sharing ideas with other folks that have been down this path and made mistakes. Right now there's about 115 consultants nationwide that are part of the Health Rosetta. One of them I'll show on the next slide as we delve a little bit more into the issues that But Dave Chase is phenomenal. There's a book called The CEO's Guide to Restoring the American Dream, which argues, and I have to agree with him, that really there's no president that's going to come in and fix healthcare. There's too much special interest. The Adam Ruins Everything video is dead on. There's a lot of lobbying, and the battles are brutal, and they're ugly, and they're getting uglier. To restore this American dream and fix that $3.65 trillion issue that we have, it kind of falls on the back of the folks in this room. Those employers and those vendors who are responsible for designing these plans, building them, and implementing them. Keep in mind, in our society, we don't have universal health care. The average middle-aged American or working-age individual looks to their employer to offer employee benefits, health care to them. That's a lot of responsibility, right? I mean, you've seen it. You've seen it in your claims. If you're self-funded, you've seen those high claimant runs. You've seen those individuals that are dealing with some of the nastiest diseases out there. And it's a sad state of affairs. The good news is you can implement some strategies to help lower those costs, return the money back to your employees, but also provide quality benefits to your folks at the end of the day. With brokers, Dave wrote a good article. Dave Contorno, he's a good buddy. He's currently involved with the Amazon Berkshire Hathaway JP Morgan initiative, consulting with them on some strategies for all their employees. If you want to talk to Dave, he's much better spoken than I am. He's pretty funny. I'm not. My wife will tell you that. I can connect you with Dave, but we've done some great business together on the direct contracting side. But his issue is, and if you think about this, every year he was handing his employers an increase at their renewal. His commission was tied to that. So what's the incentive for me as a consultant to come in and try to drive down your costs when I'm guaranteeing myself a bonus just by passing to you probably what is the easiest thing to do? Say, all right, here's your renewal. Here's a 70% increase. Here's a less crappy renewal at 30% increase. This is where you should go. So we have quite a few people in the marketplace that have flipped the script in a lot of ways to put in things like a performance guarantee. Meaning, and I'll use an example, there's a 1,500 life group in North Jersey. They're spending $22 million annually on their health care. $22 million. The broker makes $350,000 commission pays. Dave goes in and says to this employer, all right, I know there's a lot of low-hanging fruit in the way that your plan's set up. Oh, by the way, did I mention they're fully insured at 1,500 lives?
Oh my God.
He goes in and says, I can implement, I know this, maybe 2 or 3 strategies that we'll show later. And I'm going to save you $2 million, and I guarantee it. Oh, by the way, I'm going to charge you $150,000, less than what your broker is currently making this. I'm going to charge it to you in a fee. If I hit that $2 million in savings, you pay me a performance bonus of $50,000. If I don't, I pay you $50,000 to $75,000 out of what my fee was. So you're flipping the script. There's an incentive to kind of go into this as a team and lay out a plan of action to really impact the plan. And the things that he was suggesting to do have been around and implemented since easily 2011. So it's not like new concepts. It's not reference-based pricing. Competing interest number 2, your PPO network. So let's see. I'll pick on something. See, looking away. Robin, if you could have any car out there, what car would you have? Truck, van, whatever. Jeep. I have. With the kiddo coming, we got rid of my Jeep Wrangler and got a family vehicle. So that's a sore subject. What if I told you, I'm going to give you a Jeep, I'm going to sell you a Jeep, and I'm going to give you a great deal. I'm going to give you 50% off on that Jeep. But you don't get to know the starting price. Is that a good deal? No. But we're told in our PPO networks, well, first, why do we have to have a network? Let me make that point. We all have car insurance, correct? Where does your car insurance tell you that you need to go to get your oil changed? It doesn't. Well, it pays for your oil change though, doesn't it? No. So why do I need a network to go to my primary care physician? Think about it. Are we overinsured? we have too much insurance involved, too many gatekeepers in this algorithm making money, keeping us held to what they define our healthcare system should be. So going back to that point, we never get to know what the list price is when it comes to these procedures and services that we're getting. We just get told that we're getting a discount, but we don't know what the starting price is. So what really is the benefit to doing that? So I show you, and I should update this for 2018, but you look at some of the common procedures, and sorry if this doesn't show up for the folks in the back. We have a hip replacement, knee replacement, gallbladder removal, laparoscopic hysterectomy, ACL repair, hernia repair, cataract removal, colonoscopy with biopsy, CT of the chest, and MRI of the brain. These are your PPO prices across the top. Fair price down at the bottom. Who in the country establishes what is reasonable and customary from a pricing perspective? Does anybody know?
Medicare. Medicare.
Professional.
Gee, it's not fair. I give it to Emily, it's her birthday.
There you go. CMS, Centers for Medicare and Medicaid Services. Some would argue that Medicare reimbursement isn't high enough. I'm from the school of thought, if you're making 100%, which is Medicare allowable, and there's 20 to 40% in there to pad that, it's not bad if you're making 20 to 40% off of what is considered reasonable and customary. So when we talk about medical reimbursement and reference-based pricing, in most cases, we're capping at what's going to be reimbursed at maybe 150% of Medicare allowable, 200%. In most instances, your health plan, you're probably paying 4 up to 16 times Medicare allowable under the guise that you're getting a discount. If we can cue up that video. I got a video to show with Dave where in this instance he's doing what we know as medical tourism. He's going to another part of the country or in some cases internationally to get a procedure done. For us, we don't have to really do that anymore. I mean, we have great providers in our backyard.
Have you ever gone to a restaurant and saw no prices on the menu? If you did, would you order anything off that menu?
Most people wouldn't take the risk of some ridiculously high-priced steak coming to them. But we do it in healthcare all the time. And afterwards, we get bills, stacks of bills, for tens and tens of thousands of dollars sometimes. My name is David Contorno, and I've been helping employers manage their healthcare costs for the last 20 years. What if we approached healthcare in a completely different way? What if we applied the same cost and quality metrics to healthcare that we apply everywhere else? Join me on my journey as I seek to find solutions to my own hernia and the surgical repair that my doctor told me I needed to get that fixed. I decided to sort of make this experiment to say, okay, let me find out what it's like to go for that normal patient experience into the normal healthcare system. I'm going to call some places, and my main goal is to find out how often they do a hernia repair, how well they do it, and what the cost is. And you're going to go on this journey with me. Hi, my name is David Contorno, and my doctor diagnosed me with an inguinal hernia. Yeah, hi, I am trying to get the price for doing an inguinal hernia repair.
How may I help you?
My doctor diagnosed me with an inguinal hernia. I just wanted to find out how often you guys do that type of repair, how well you do it, and how much it costs.
Start-out price is $40,780.
Okay.
$58,774.94. You're looking about $1,500.
$1,500?
No, I checked with Lisa, my supervisor. She really didn't know the answer to that question. We were just Googling online.
Gotcha.
We just Googled it.
This is so ridiculously complex.
Your call is very important to us. Please hold.
Is it? You transfer me to anesthesia first. You know, this whole process is kind of archaic, don't you? It'd be like if I wanted to get a price on a TV and I called Best Buy and they said, well, here's the TV price, but you gotta call somewhere else to get the price on the remote control and somewhere else to get the price on the electrical cable you need to plug it in. Do you agree? So in my quest to find facilities that actively publish their pricing and quality data, I came across the Surgery Center of Oklahoma, which founded this movement in the early 90s. Watch what happens when I call them and ask the same questions.
Surgery Center of Oklahoma, this is Tiffany.
Hi Tiffany, my name is David Contorno, and I have an inguinal hernia on the right side of my groin that I need repaired. I want to get some ideas around cost having that repaired at your facility.
Okay. And you said an inguinal hernia repair. Our self-pay price for that procedure is $3,060. That includes the surgeon, facility, and anesthesiologist.
Oh, wow, I mean, we've been having to call all separate places to get that, so you already know what all those are gonna be in advance?
Yes.
Hey, question, who can I ask about like frequency and quality stuff there?
Marilyn, our director of nursing, might keep track of that. Do you want me to try and get you over there to her?
Sure, if you don't mind.
Hi, David.
Hey,
This
man.
is Marilyn from the Surgery Center of Oklahoma. You called us once from staff.
Yes,
I think the three questions were if we've had any infections,
yep,
and the answer is no.
Okay.
With inguinal hernias, there've been no readmissions for complications,
okay.
and we've done from December of 16 to November of 17, which is a year. We did 313 hernia repairs.
Wow, that's impressive. Awesome.
Was there anything else?
No, I think that's it.
Okay.
Thanks so much, Marilyn. So I got some cash out at the ATM machine at the airport, and I'm now paying for my surgery in cash. I paid the $200 over at the doctor's office, which was part of his payment. Now I'm just arriving at the Surgery Center of Oklahoma. Gonna walk in and see what this intake experience is like, and see how it goes.
I think it's time the buyers of healthcare, they begin to very seriously question that big discounts off of billed charges make sense. This has been a disaster. As Dave Chase has said, it's possibly the biggest heist in the history of this country.
So just finished the surgery. I'm still a little groggy from the anesthesia, but everything seems to have gone well. I mean, high quality drugs they gave kept me out. Everything's done. All in all, seems to have been a success. So I'm 4 weeks post-op, and I feel fantastic. I already went skiing 2 weeks ago. The experience was wonderful. The facility was super high quality. The nurses and the doctors and the staff were second to none. And so, what was different about this journey? How did this change fundamentally both the approach and the outcome from the standard experience? Well, I put healthcare first. I cared about cost and quality. I actually demanded it. And I didn't go to a place that couldn't give me those metrics. So I made sure that I was going to the highest quality, lowest cost facility that I could. So let's do the math. Well, I could have gone to the $47,000 place, and I have a $12,000 deductible and out of pocket on my family high deductible health plan. So I would have owed the $12,000. My health plan would have paid $35,000 on top of that. And maybe I would have had the same outcome, maybe I wouldn't. But instead, by putting healthcare first, I paid $3,060, add in travel and hotels, and I'm still under $4,000. And here I am sitting before you, 100% recovered, and ready to do this the next time I need to encounter our healthcare system. So join me on this revolution, one in which we put healthcare first, and see how it changes your financial and your physical.
Pretty cool, right? Thanks, Bill. So, interesting thing, it's kind of like wine, right? Cost and quality are inversely related. Same thing applies to medicine. From a transparency perspective, can anybody name a medical procedure that isn't covered on a health plan that because of transparency and true competition has done nothing but drastically decrease in price over the past 15 to 20 years? LASIK. Heck, they even got specials up the road. Buy one eye, get the second eye free. Just kind of thinking about a different perspective. Two other things that I want to throw out there, and these can be up for grabs too. Does anybody know, I'm sure if you talk to a financial advisor, what the estimated amount you're gonna need as a couple in retirement for medical expenses is now? With the current trajectory? 275. Sad stat that came out in an article in the Wall Street Journal last month. What percentage of all new cancer diagnoses will end up in medical bankruptcy? Any guess?
52%.
A little bit lower. Who said 40? Back in the back, 42%. Staggering. Personal story. My aunt, as John had said, I'm from Bedford, Pennsylvania. Anybody been to Bedford? Omni Bedford Springs was dilapidated when I graduated from high school, and then the Omni came in and dumped 99 million. So if you have an opportunity to check it out, it's really cool. Outside of the Springs Resort, the only thing to do there growing up was the cow tip or drink beer. Not a whole lot to do. What's that?
Fish out there.
There's great fishing. There is.
Yeah.
Great hunting too. But my aunt, manager at Denny's outside of the turnpike, all right, hardworking lady, 60, 70 hours a week, taking care of her kids and her grandkids. Recently diagnosed with stage 4 cervical cancer. The two reasons she didn't go to the doctor outside of fear, because symptoms are scary, right? One, I can't afford my out-of-pocket costs if I go to the doctor. Two, I can't afford to take time off work. That shouldn't exist in our country, but unfortunately it does. As far as local providers that do a great job, hospitals have a place in the care algorithm. If you have comorbid conditions, if you have a lot of stuff going on, you should get all your general surgeries in an inpatient hospital setting should something go wrong. However, most people are healthy enough for surgery. Places like OSS, OIP, you get great care, quality outcomes at a fraction of the price. For a self-funded plan, you can engage your employee population and incentivize individuals if they make a choice to go to those facilities. Waive your out-of-pocket costs. Give them a cash incentive for utilizing that choice, or making that decision. Section 162 of the IRC says that you can bonus an employee for anything. Why not bonus them in their paycheck as a taxable incentive for making a high-quality choice in their care? Carriers. Thousands of them, right? No, there's only like a few. Consolidation, similar to the PBMs, similar to the hospital systems and providers now. You have what we call, as an industry term, and Bob, you see me post about this, BUCAs, Blues, United, Cigna, Aetna. Outside of that, there's not really a whole lot of other ones, Humana. The BUCAs, the insurers, like I said earlier, they're not 100% to blame. Can they take some blame? You saw the video with Adam Ruins Everything. The guys shaking hands between the charge master at the hospital and the insurance carrier and establishing what these discounts are, which are all proprietary. You know, they won't tell you what their network discounts are or what price it's off of. But when we go back to the Affordable Care Act, there was something written into law that makes it very interesting for how an insurer does business, and that's the 80-20 rule. 80%, if you remember, 80% of all premiums have to go towards paying claims, 20% can go towards marketing, administrative fees, etc. So really the only way for an insurer to make more money is to charge more premium. And this is evident in carrier stock price since the ACA passage. My good friend Brian Klepper, who is another guy that you should follow, talk about a guy that's very passionate about this business and this industry and trying to fix healthcare. He lost his wife to breast cancer years ago, and they got chewed up and spit out in that system. Ended up almost medically bankrupt. But it's his goal now, and he's since remarried to a lovely lady named Sue down in North Carolina. He's since gone after and called to the table a lot of things that we see wrong in the industry. He used to sit as the president of the National Coalition on Health. However, he made a statement once, and the board let him go, that if you're working with some of the big houses or the major insurers to try to fix your healthcare issues, you're working with the wrong people. Now, they also happen to be the big sponsors for the National Coalition on Health, so as you can imagine, politically he got let go. But this could be updated since August 24th of 2018 to say that if you ever hear insurers whining that they're not making any money in the current environment, they they've posted record profits year after year after year to the tune of probably at this point 39 quarters. It begs the question, who really is their customer? Is it you? Is it providers? I'll share with you because we do some niche TPA work, direct contracting. That's why we work with brokers and consultants across the country and helping establish some of these nuanced plans. Get a call from one of the major blues out in the Midwest, and they were in a conundrum. They had contracted with a couple dialysis providers for end-stage renal disease. Anybody familiar with ESRD on their plans? Pop quiz. What month can an ESRD patient come off your plan and go into Medicare? John, 32 months, John gets it. But if you look at your high claimant reports or you look at your runs, ESRD patients are astronomical. They cost a ton. So Blue Cross Blue Shield reaches out to us and they say, hey, we got your name from somebody else out here in, I can't even state, I'll get away to the ECS. We're hitting a conundrum. We have a group of 3 employers, well over 120,000 lives, and they've identified another dialysis provider that's about 90% cheaper than what we're charging. 90%. Problem is, we can't adjudicate these claims even though they want these people to be in-network because we'll tick off the providers we've already contracted with. But we don't want to lose these accounts. Will you give a plausible deniability to come in and adjudicate these claims so that we can step back and not be caught red-handed? These are the types of conversations that go on behind the scenes. And in any other industry, it'd be considered, what, fraud, right? Price fixing. But in ours, it runs rampant. Self-funded employers in the room? Okay. So self-funding's changed over the past decade. People down to 50 lots are self-funding now or doing some hybrid form of self-funding. I know for us, we've done medical expense reimbursement plans or HRAs for a number of years, which I can argue is a hybrid form. A couple things to keep in mind if you are self-funded or you're looking to go self-funded. Your stop-loss contract under special risks and limitations, especially if you're considering going in a consortium, make sure you understand the terms of that stop-loss agreement and the penalties involved should you decide to leave. Here, if you terminate your contract, you owe 80% of your individual stop-loss premium, your spec, as well as 100% of your aggregate stop-loss premium for that year if you decide to leave. Captives, there's some great captives. There's also some captives that are built to make a lot of money on capital that's saved in reserves that you never see at the end of the day from interest and investments, as well as position your stop-loss contracts so that you don't have the ability to get out without undue exposure and risk. So make sure, this is a term you should ask every single person, what's my run-out protection? Every single consultant, captive, insurer that you're working with, what is my run-out protection when this contract ends? The other thing that you should look for, and these are going away, but in the blues, you look here, PPO access fees. So most of us, anybody have a national footprint or outside of one state you have employees? Okay. Look for terms regarding access fees. They like to slide them in the contract. Access fees are charged when you step outside of your network and access somebody else's network. So if you're using Highmark or CBC or IBC and you go into Ohio and use Anthem, we've seen up to 5% tacked on to every claim for that employee utilizing that other network. You can get those removed, you just have to ask. So I started in this industry, pharmaceutical industry. I wish I could say that it's not corrupt. There's a lot of good that's done. I mean, a lot of drugs save lives, but there's a lot of perverse interests in your PBM plan. For sake of time, I'm going to speed things up a little bit. PBM is probably the area that we see, if I had to use a term, probably the most fraud or nonsense that takes place. It's also something that every single one of you has the power to control. One thing that I'll show later on is the fact that you are a fiduciary on your plan. You're responsible to be prudent in how you spend those funds as well as the commingled funds of your employees. That being said, in every single instance, all these people that I've mentioned so far, the insurer, the consultant, the PBM, talk about independent TPAs, they waive fiduciary responsibility. So, and employees are getting wise, they're starting to ask questions on why we're designing the plans the way we are and what the employers are spending our money on in our premium. There's lawsuits that have popped up. Similar to what happened in the wealth management industry when people were asking questions regarding their 401k and undue fees and things that were built in from that perspective. But from a PBM perspective, this is what you're looking at. This is the matrix of a PBM and how the drug comes from the manufacturer, all the avenues that come down to the end user, the patient. It's pretty simple, right? Now, as a consultant, I can make money in the TPA, I can make money in the PBM, I can, make money from the employer. There's about a million different ways I can make money and slot in $1 PEPM. I can make a percentage of some of this. Ask your consultant, it's your right to ask, where are you making money? Not everything is reportable in a Schedule A 5500. Something that I didn't mention back on the insurance portion, if you have a stop loss contract and your broker's making commission on stop loss, tell them not to. Anytime you add in 3 to 5% commission on your stop loss contract, that underwriter's bumping it up to 10%. It's just the industry standard between stop loss underwriters and MGUs, managing general underwriters. There's no need to make stop loss commissions. Fee-based is the way to go. Where do PBMs make their money? We think about one of the largest, CVS Caremark, we would automatically assume maybe the retail stores, right? They have all these locations throughout. It's actually not their biggest profit center. Their biggest profit center is with their PBM. The growth stemmed from CVS Caremark, and this is 2017, but was due to higher pharmacy claim volume, higher brand prices, and increased specialty drug volume. And that's apparent across all PBMs. The PBM industry is a $500 billion industry right now. Ton of money to be made on the backs of the employers as well as the employees. And the lobby is fighting tooth and nail to keep any sense of transparency out of the discussions at the state level. Did anybody catch the announcement last year regarding the removal of gag clauses at the pharmacy level? Nick, you know about this. Yeah. So up until a few months back, Blair County Senator, I think, led the charge in this, or Representative Ward. If you went to a pharmacy, the pharmacist couldn't tell you a cheaper alternative for a drug because of gag clauses. Now if you go in and talk to your pharmacist, they can communicate to you an equally as effective or efficacious drug at a lower cost to you. The other thing that I would highly suggest everybody download, encourage their employees to do, check out too, is GoodRx. You guys seen GoodRx? Commercials are out there. Going to save plans or people $1 billion this year. Easy access to manufacturer coupons. It's kind of funny. I go into, well, full disclaimer, I work for a benefits company. We got great benefits, but my wife's a school teacher at Hershey, and school teachers have really good benefits, so I'm on her plan at this point. We moved in July after I got married. But I go into Rite Aid on Chocolate Ave, and I go in to get my $10 cash blood pressure medication, all right? That's you throw down my card, the insurance card. I then get an explanation in the mail regarding what the cost to my plan was for that prescription. So cash pay, $10. The copay was the same, $10 utilizing her plan. Anybody guess what they charged my plan or her plan? How much?
$50.
Oh my God.
125. 200. 300.
A little bit less than 200.
189.95.
You said 200, right? It was $109 or $190 for a blood pressure medication. So I take a snippet of that and send it to the Auditor General, Eugene De Pasquale. We're getting together here in a few weeks. I don't know if you guys follow him online and some of the work he does. He's pretty cool. He's a Star Wars nerd like me, so we nerd out over stuff like that. But he's identified the issues that each of us taxpayers are essentially paying for these plans, which in turn pay for these drugs. And he's trying to address them as best as possible. The problem is, and I don't care if it's Democratic or Republican because we've talked to both, there's a lot of money that's backing these politicians, and unfortunately their decisions as well. So it's hard to pull the wool out from some of the folks that are out there and incorporate these changes. Unmasking the middleman. Spread pricing and the rebate system. People familiar with spread pricing or rebates? Two things in your PBM contracts, which I very much encourage you to do a carve out of your PBM contract. Work with a fiduciarily responsible and transparent PBM. There's two things in there that you should have removed. One removed, the other one some different version around it. Spread pricing. The spread price is the difference between what the PBM charges the health plan for a drug and what it reimburses the pharmacy for it. The pharmacy doesn't know what the health plan pays the PBM for the drug, and the health plans don't know how much the PBM reimburses the pharmacy for dispensing it. PBMs use this lack of transparency to keep spread as a profit, which in any other industry would probably not be legal. But in this industry, that portion of the spread, which will be shown later on as an administrative fee, is extremely profitable for the PBMs and drives a lot of revenue. The other area, rebate system. What's a rebate? You overpay to get a portion of your money back. Well, a lot of the PBM contracts are rigged to function from a profitability standpoint on rebates, meaning they're going to adjust that formulary to capitalize on the amount of money that they're getting from those manufacturers and only give you a percentage of that back. It's amazing when you carve out a PBM for an employer, self-funded employer, and they get a check back in the form of rebates when it's 100% transparent, and they get a check for $100,000. They're like, what is this for? Well, that's money that you should have been getting all along from the manufacturers direct. Here's a good example. We all know about the rising costs for things like EpiPen and drugs that have been on the market for decades, insulin. They're rising up. Here's where a lot of folks are making money. Manufacturer, in the case of the EpiPen, $274. The PBM, insurers, brokers, $284. Wholesale at $20, the pharmacy $30. It's not really fair, right? Why is the middleman making way more money than the other players in here? Interesting industry case here. So Dr. Garris from Creighton University, he passed away a few years ago. PharmD, he developed a software and algorithm to go in and essentially identify on plans where spread pricing was taking effect. Now, the guy believed in his mission. He was kind of the impetus for a lot of lawsuits that happened in the PBM industry that quickly went away for a number of reasons. But ultimately, his software, he put in his will, he didn't want it going into the wrong hands. So there were some of the big PBMs that tried to buy it. There's a few folks out there, pharmacists that he trusted that have that technology. There's one or two PBMs that access it as well that are considered fiduciary and transparent PBMs. Just kind of interesting. Down the bottom here, we take an example of NDC codes from 5 different PBMs. It's another area that PBMs involve trickery, if you will. NDC codes, depending on how they package the product to send it to you or deal with the pharmacy. They can manipulate those numbers, which manipulates average wholesale price, and then they can tell you on the front end, we're going to give you X amount of discounts. But once again, we go back to the whole discussion regarding what's your starting price. At the end of the day, if it's not fully transparent or you're not using a standardized NDC code, you're essentially getting ripped off. And what's even sadder is some of the pharmacies are getting ripped off because they're not getting paid squat from a dispensing fee perspective. So these are just a couple different examples of spread pricing. Gets worse in the specialty drug area. We had an unfortunate case of two twins that were on a specialty drug that cost $60,000 a year. Doctor was a speaker for the pharma company and put them on an extended release drug that cost $75,000 per twin per month. Right? Can you imagine a $1.5 million liability on your health plan that just pops up out of nowhere because of a decision that a physician made, saying, oh, well, you only need to take this drug now twice a day as opposed to 4 times? Made the kids sick, unfortunately, anyway, and they came off the drug and went back on the original drug. But it's still very shocking when you see your claims runs come through and that pops up. Don't chase rebates. If you have somebody pitching rebates, rebates are a bad game to play in your PBM contracts. Ultimately, I said earlier, they manipulate manufacturer rebate and formulary to maximize how much of this money is kept by them. This is a lawsuit between an employer, Calio manufacturer, pharmaceuticals, and Express Scripts. Just real quick, rebate passed to the employer versus what was kept by the PBM as administrative fee. Only 7% of that rebate ever made its way back to the employer. There are some great solutions out there. What I will encourage you, if you're making the switch from fully insured, which you really don't have any transparency and no way to really impact and control your costs outside of that renewal that's flipped to each year, you're moving towards self-funded, you're gonna be able to take better control of your plan. I wouldn't chase savings in the 30% area, these fixed costs. Really focus on claims. Claims are the issue. Somebody in our industry always says it's the price, stupid. Focus on the price. Okay. Under ERISA and the Department of Labor, I had mentioned you have a fiduciary responsibility to oversee these plans. The 3 fundamental fiduciary duties under ERISA Section 404A. Plan fiduciary must discharge his duty solely in the interest of participants and beneficiaries, in accordance with the documents and instruments governing the plan, for the exclusive purpose of defraying reasonable expenses of administering the plan. That I stole from Adam Russo, the ERISA attorney. He will tell you, as most of us in the industry, it's your plan. You can do what you see fit with the plan. You can amend the plan document 10 ways to Sunday to benefit you and the employees. I encourage you to try and do so. I like comics. A couple things all plans should be doing right now. And this has been around for the better part of 8-9 years, post-ACA. Building a better health plan, full transparency and reporting, encourage an independent TPA. Carrier ASO model, 90% of claims hit a system, pay, auto-adjudicate, apply the discount. Independent TPA, probably about 60% of those. You have a little bit more oversight, okay? In conjunction with an independent TPA, you also have the ability to do things like reference-based pricing. We talked earlier about CMS, Medicare allowable. You can write your amendment and your plan document to state that we will not pay any more than 200% of Medicare allowable. That's the basis of reference-based pricing, and there's some great vendors out there that I encourage you to check out regarding RBP and how to structure these plans. We talk about balanced billing. I guarantee every one of you folks in a PPO right now are getting balanced billed today. It happens whether you're in a PPO or you're in an RBP plan. Think about a hybrid where you have a PPO plan, then use RBP for all your out-of-network claims. Like Adam ruins everything said, out-of-network hospitals are a disaster for plans. PBM carve-out and oversight, employee price and quality transparency, education like Healthcare Blue Book, going to the right appropriate provider, but also the right price for that provider. Al Lewis with Quizify, the guy's an awesome dude. He was on Jeopardy only once, so he didn't win. But he has a great tool for educating your employees. Proactive disease and wellness management, understanding your data. For example, you got people going to the ER. Why are they going to the ER? In one case, they couldn't afford their insulin, these diabetics, because it was too expensive, make it free on the plan. Now you've curbed that ER problem. You've also helped your employees lead a healthier lifestyle with the appropriate education and free insulin. High claimant billing and clinical review. We live in a very archaic system. There's a lot of mistakes that happen in bills. If you have the ability, audit your plans. Direct contracting, we do it now. Gary does it, Bob does it. It's very easy to contract with local providers and save a lot of money on such things as labs, dialysis, general surgical procedures like orthopedics, big one, imaging. You can go to WellSpan, you can go to a hospital south here and pay 10 grand for an MRI. Or you can go to a standalone facility and pay $800. It's a big difference. RBP, claim doc we like a lot because they indemnify each of their reference-based price claims. If something goes to litigation, they fight it, comes off your plan. Specialty drug sourcing, both domestic and abroad. I can talk about that real briefly. Under the Department of Health and Human Services, Eric Hargan, the Deputy Director, has written it that as long as you're on a life-saving and life-sustaining drug, you can self-import up to 120-day supply of that drug. So if I have a hemophiliac on the plan that's costing me $1 million, they can fly down to the lovely Cayman Islands, go into Health City where Kirk Cousins goes and gets injections on his knee, and walk out after I give them a bonus and pay for all their travel, and now it costs the plan $200,000 as opposed to $1 million. All things that you can do and voluntarily the employee can opt into. And then tech-based solutions like direct primary care, which is extremely easy to implement and I think very feasible for most your doctor and say, hey, my kid has a sore throat, what are they gonna say? Well, I need to see them. Why do they need to see them? Because they need to justify why the kid's coming in and get paid. Otherwise, you can pick up a phone and use the high-def camera, show your kid's throat, and get a prescription written over the phone. It's just about common sense solutions and making it easier for you and your employees at the end of the day. Walmart just went and changed their primary care visits. Primary care visits are $40 now, or if you use Teladoc, their employees, it's $4. Big incentive. Very reasonable. This is a small, mid-sized employer. Reference-based pricing, cap exactly what you're willing to pay. Obviously, you're going to save across the board as opposed to what you would be paying through your PPO, and that impacts your employees as well and their out-of-pocket expenses. Simply put, if you want to pay less for healthcare, pay less for healthcare. You can go on Health Rosetta's website. All of these things are up there. Ton of education. Like I said, if anybody wants the CEO's Guide to Restoring the American Dream, shoot me a note, shoot me an email, shoot John an email. He'll get you in contact, or Jamie. I'll send you a copy digitally. And for sake of time, I'll wrap it up. Yep. Yeah, it is in Pennsylvania. A couple months ago, interesting enough, I